So can we start? Yes. So can we start with today's session? Please let me know the response on your comment box. Yes. Okay. Okay, so I'm going to start with the first chapter in paper 2, that is blood vessels and heart. So, as far as the chapter blood vessel is concerned, you must know atherosclerosis, risk factors of atherosclerosis, structure of atherosclerotic plaque, what is the possible case scenario they will give in a case of an atherosclerosis, a patient who is a chronic smoker, chronic hypertension, okay, um, currently presenting with a history of transient chest pain, which is exaggerated on exercise, relieved by rest. So it is a case of an angina. See how to myocardial infarction, the case scenario, there will be typical presentation, that is squeezing type of chest pain. Okay, the patient will come so squeezing type of chest pain, which is associated with the radiation of the pain to the jaw and what left arm. So this is the classical scenario you should expect in case of myocardial infarction. So atherosclerosis is important, myocardial infarction is important, the electron microscopy, light microscopy, and gross morphological changes of myocardial infarctions over a period of time, starting from few minutes over hours. That is the final stages, the collagen deposition and fibrosis. You must know that table. Okay, many MCQs you will get from that table. What is the earliest light microscopy finding? What is the earliest electron microscopy finding? All these are very important questions. So make sure you study atherosclerosis and myocardial infarction. Then next important thing is aortic dissection versus abdominal aorta aneurysm. That is two important probable questions. One is aortic dissection. A patient who is having long or tall stature with what arachnodactyly, that is elongated digits, comes with complaints of severe squeezing type of chest pain radiating to the back of the scapula. On examination, low BP, high heart rate. What is your diagnosis? Marfan syndrome, squeezing type of chest pain. Always think about aortic dissection. You must know what is the etiology and what is the morphology of aortic dissection. And aortic aneurysm, they may not give the as a case scenario, but as a short-term question, they can ask it separately, what is aortic aneurysm. Then another most important question when it comes to the chapter of blood vessels is the vasculitis spectrum of diseases. In vasculitis spectrum of diseases, number one question, giant cell or temporal arteritis. And number two question, it is Takayasu arteritis. Number three, polyarteritis nodosa. Number four, venous granulomatosis. These four are must-known questions. Okay, these four are must-known questions in the chapter vasculitis. So, giant cell arteritis, a female or a male 60 years comes with severe chest pain. Okay, the patient will have a typical pain along the temporal side of the head. Okay, associated with loss of vision. Always think about temporal or giant cell arteritis. Biopsy is the definitive investigation of choice in case of giant cell arteritis. In Takayasu arteritis, feeble pulse in the upper limbs, lower limb pulse normal, BP normal. You have to think of Takayasu arteritis. Polyarteritis nodosa is important. Vaginous granulomatosis is important. In vaginous granulomatosis, remember there is both involvement of the upper respiratory tract. There will be glomerulonephritis also. Okay, so pulmonary renal manifestations. Always think about vaginous granulomatosis. Once that is done, let us go for the next Important question, that is Kaposi sarcoma. Remember, Kaposi sarcoma is what type of malignancy? It is a benign, or it is a borderline, or it is malignant. Yes, can anybody post in the comment box what type of malignancy is Kaposi sarcoma? What type of malignancy is Kaposi sarcoma? Whether it is a benign, borderline, or a malignant variety? Yes, can anybody put it in the chance box? Malignant, is it malignant? See, there are two examples huh, for malignant what vessel disorders. Okay, I will take. It is intermediate grade. Don't get this question wrong. It is intermediate grade. Okay, Kaposi sarcoma is intermediate grade type of tumor. So make sure you are studying the classical variety of Kaposi sarcoma, endemic, epidemic. Okay, there are AIDS, HIV associated Kaposi sarcoma. Okay. A clarification, sir. HIV is associated with FSGS, but you have mentioned membranous nephropathy. Yes. See, the question is, there are two different things you have to remember. Okay, there are two different things you have to remember. What is the most common? Yeah, I will clarify 1 second. What is the most common nephrotic syndrome if it is associated with HIV? If they say, as per what our university, you can go with FSGS, but when the same question is asked as an essay question, okay, when it is asked as an essay question, a HIV patient comes with a nephrotic syndrome picture, you should have write membranous nephropathy as an answer. But in MCQ, if they are asking what is the most common type of nephrotic syndrome seen in HIV, in that option, if FSGS is there, go with FSGS. FSGS, that too collapsing variant of FSGS, is very closely associated with HIV. But in case scenario based question, essay question, okay, when they give a history of nephrotic syndrome, a 50-year-old male, maybe HIV positive, a sexually active male or a female, when they ask about what is the diagnosis, go for membranous nephropathy. Okay, hope you are clarified. Anonymous, yes, hope you are clarified that. Say yes or no. Fine. So remember Kaposi sarcoma. Okay, remember Kaposi sarcoma. Okay, once that is done, let us go for the next chapter. Next chapter is what? Okay, thank you. So blood vessel vasculitis done. In heart, number one, rheumatic heart disease. Number two, infective endocarditis. Number three, I have already mentioned, it is myocardial infarction. You must know myocardial infarction. You must know. Number four, short note question, dilated cardiomyopathy associated with titin mutation. Number two, hypertrophic obstructive cardiomyopathy associated with beta myosin heavy chain mutation. These two cardiomyopathy very, very important. MCQ question they are going to ask, ninja star nucleus is seen in dilated cardiomyopathy. Okay, boxcar nucleus is seen in hypertrophic obstructive cardiomyopathy. Restrictive cardiomyopathy is associated with amyloidosis. What type of cardiomyopathy is associated with amyloidosis? It is restrictive cardiomyopathy. Once that is done, make sure you read viral myocarditis. This year I am expecting this question, viral myocarditis. Second question I am expecting this year is atrial myxoma or rhabdomyoma. Okay, atrial myxoma or rhabdomyoma. Atrial myxoma or rhabdomyoma. Okay, I hope this is very clear for you. Yes. So that's about the two chapters. Important, most salient, must know things I have already mentioned. Coming to the chapter of lungs. In the chapter lungs, make sure you study chronic bronchitis versus emphysema. Okay, pink puffers versus blue blotters. Different types of emphysema, different patterns of emphysema. That is very, very important. Okay, different patterns of emphysema. That is extremely very, very important. Different patterns of emphysema is very, very important. Once that is done, make sure you study lung abscess. Make sure you study lung abscess. Make sure you study lung abscess is a short note question. Okay, don't expect that they will ask us a case scenario. They may ask us a short note, straightforward short note question, lung abscess. Then typical pneumonia versus atypical pneumonia, various stages of typical pneumonia. There is congestion, red hepatization, gray hepatization, resolution. Very, very important. Make sure you study those. Once that is done, next question is interstitial lung diseases. Silicosis, asbestosis, coal workers, pneumoconiosis. A patient working in shipping industry comes with breathlessness, dyspnea. X-ray shows bilaterally infiltrate or opacities, diffuse opacities. FeV1 by FVC ratio is normal to high, what is your diagnosis? Restrictive lung disease. That too, occupational lung disorders. Occupational lung disorders. Asbestosis is important. Asbestos bodies, ferruginous bodies, all those are important. Okay. One MCQ question this year I'm expecting. Mason bodies are seen in. Mason bodies are seen in. I'm putting in my chat box. Okay. Mason bodies are seen in. Mason bodies are seen in. Cryptogenic organizing pneumonia. Ooh, cryptogenic organizing pneumonia. Mason bodies are seen in cryptogenic organizing pneumonia. Okay. Okay. Once that is done, the next question I am expecting is lung carcinomas. Make sure you study adenocarcinoma, squamous cell carcinoma. Squamous cell carcinoma associated with what? Keratin pearls. Adenocarcinoma, glandular pattern. Adenocarcinoma in situ, we have a characteristic pattern called as lepidic growth pattern, or a butterfly sitting in a fence pattern. Butterfly sitting in a fence pattern. Small cell carcinoma associated with Asopardi phenomenon. Very, very important. Asopardi phenomenon. MCQ I am expecting. What are the small cell carcinoma markers? Small cell carcinoma markers. Remember, small cell carcinoma has the strongest association with what? Smoking. Chromogranin, CD56. Okay, chromogranin, CD56. Two important markers. Okay, important small cell carcinoma. Thyroid transcription factor, TTF, napsin. TTF and napsin are two important markers of adenocarcinoma. P40 and P63 are two important markers of squamous cell carcinoma. From the four things what I have mentioned, squamous cell, small cell, and adenocarcinoma, one question this year I am expecting. What are the markers? Asopardi effect important. What is the typical case history of a patient with lung carcinoma? 56-year-old male comes with complaints of weight loss, loss of appetite, hemoptysis, chronic smoker for last 20 to 30 years. Investigation specify lung malignancy, explain the gross and histopathological cases. A rare question which can be asked is carcinoid tumor of the lung, which characteristically produce collar button lesion. Another MCQ. Collar button lesion is seen in carcinoid tumor of the lung. That's done. Then TB I have already mentioned in paper 2, very, very important. From head and neck. Head and neck. What questions I am expecting? Number one question, pleomorphic adenoma of the salivary gland. Pleomorphic adenoma of the salivary gland. Second question, carotid body tumor, glomus tumor. Carotid body tumor or glomus tumor. Third question, squamous cell carcinoma of oral cavity. Squamous cell carcinoma of the oral cavity. Fourth question, esthesioneuroblastoma. It is nothing else but tumor of the olfactory epithelium. All these things I have mentioned in my YouTube videos. You can go to the Prof Series playlist. In that I have very clearly mentioned about these important questions from head and neck. Okay, once that is done, let us go for the next chapter, GIT. First essay, CA stomach. Second essay, CA esophagus. Third question, Barrett's esophagus. Fourth question, CA stomach. Stomach, esophagus, colon. Very, very important essay. And another one important essay, Crohn's disease versus ulcerative colitis. Crohn's disease versus ulcerative colitis. A male presenting with recurrent blood stools, weight loss associated with some biliary, hepatobiliary diseases. Okay? But the barium investigation shows lack of hostrations. Hostrations are seen in colon. Lack of hostrations. Ulcerative colitis mainly affect the colon. Ulcerative colitis. Crohn's disease. Celiac disease. Very, very important. Celiac disease. The most specific antibody in celiac disease is anti-tissue transglutaminase antibody. Anti-tissue transglutaminase antibody. Remember, anti-gliadin is outdated. Anti-gliadin is outdated. Currently, if they ask MCQ, what is the most specific anti-tissue transglutaminase antibody? What antibodies you can see in Crohn's disease. Anti-Saccharomyces cerevisiae. Saccharomyces cerevisiae is yeast. Very, very important. I'm expecting anti-Saccharomyces cerevisiae antibody seen in Crohn's disease. Should we study sideroblastic anemia, considering that this topic is not given in Robbins? Sideroblastic anemia may not be asked. Mostly it won't be asked. Just remember one point. What vitamin is used in the treatment of sideroblastic anemia? It is vitamin B6. That single point you understand. And rest are laboratory parameter. That is TIBC, ferritin, all those. No, you put opposite to iron deficiency anemia. You know the lab parameters in iron deficiency anemia. No? Just put an ulta, reverse. Okay, that is TIBC is high in iron deficiency anemia. That means it is less in sideroblastic anemia. Serum ferritin is less in iron deficiency anemia. It is high in sideroblastic anemia. Vitamin B6 is the vitamin which is used currently for the treatment of sideroblastic anemia. That single point is important. Pappenheimer body is remember, and next is sideroblast. Remember. Ring the sideroblast, Pappenheimer bodies. Okay, all those. Just enough. That's enough. Okay, so Crohn's disease I have told you. Barrett's esophagus I have told you. Peptic ulcer disease. A patient who is a software engineer having irregular food intake comes with the complaints of what? Epigastric pain. What you have to suspect? You have to suspect peptic ulcer. Duodenal ulcer versus stomach ulcer. H. pylori gastritis is important. Maltoma is important. I have already told you carcinoma of esophagus is important. Maltoma is important. Celiac disease is also important. Anti-tissue transglutaminase antibody, most specific antibody in celiac disease. Okay. C colon, that sequence is important. Adenoma carcinoma sequence. What is the mnemonic I will say is AK57. That is first is APC gene, AK. Okay, AK57. K for KRAS and AK53. Okay, you know AK47. So this is AK53. That is first gene is APC, second gene is KRAS, third gene is P53. This sequence has been asked once in your MCQ. Okay, what is the correct sequence? Adenoma carcinoma sequence. First APC, then KRAS, then comes in the final stage P53 tumor suppressor gene. Make sure you are studying top to bottom about colon, CA colon, right-sided colon as well as left-sided colon. How will you be differentiating between peptic ulcer disease and gastritis? Clinically, you can't differentiate between peptic ulcer disease and gastritis. So, whenever you get a case scenario, you can write this. Most probable diagnosis is peptic ulcer disease bar gastritis, and explain about what the type A, type B gastritis, H. pylori gastritis, everything you explain. You can't differentiate if it is a peptic ulcer disease versus gastritis clinically. You need endoscopy and then other imaging modalities for that. Okay, so when they ask it is compared to peptic ulcer disease, I will say gastritis is a better option, but still you can say peptic ulcer disease bar gastritis and explain about type A, type B gastritis and all those things. Type A for A. Type A is autoimmune associated with pernicious anemia. Okay, so CA colon important. Next, very, very important question that I am expecting is Peutz-Jeghers syndrome. A child or a male 19 years old comes with complaints of recurrent blood in stools associated with episodes of constipation and diarrhea with mucocutaneous pigmentation. Okay, that is melanin pigmentation in the oral cavity lips. What is the diagnosis? Peutz-Jeghers syndrome, autosomal dominant, STK11 mutation, associated with what? Hamartomatous polyp, Christmas tree appearance, arborizing pattern of polyps. Bowel movement differential. 60-year-old male comes with altered bowel movement. The only one diagnosis that has to come into your mind is carcinoma of the colon. Maybe right-sided colon or left-sided colon. More commonly left-sided colon. Left-sided malignancy present with altered episodes of diarrhea and constipation. Right-sided colon malignancy mainly present with iron deficiency anemia, right iliac fossa mass. So altered bowel movement, 60-year-old, always for you in university exam, it is CA colon. Fine, that's done. Next chapter, hepatobiliary. And very, very important, which malignancy has the highest risk in Peutz-Jeghers syndrome? Expecting this question this year, which malignancy has the highest risk in Peutz-Jeghers syndrome? Whether it is CA colon or whether it is CA pancreas. Answer is CA pancreas. Carcinoma pancreas has 100 times risk in a patient with Peutz-Jeghers syndrome than carcinoma colon. So, which malignancy has the maximum risk in Peutz-Jeghers syndrome? Your answer should be carcinoma of the pancreas. In pancreas, make sure you are studying both acute as well as chronic pancreatitis. Okay, both acute and chronic pancreatitis. A patient who is coming with a complaints of severe epigastric pain radiating to the back, chronic alcoholic, associated with elevated serum lipase, elevated serum amylase, diagnosis acute pancreatitis. Acute pancreatitis. Chronic pancreatitis won't be asked as a case scenario. Acute pancreatitis can be asked. Chronic pancreatitis can be asked as a straightforward short note question. Once that is done, make sure you are studying about acute versus chronic cholecystitis. Acute versus chronic pancreatitis is important. Acute versus chronic cholecystitis is important. Acute versus chronic pyelonephritis is important. A female who comes with an episode of fever associated with recurrent episodes of urinary tract infection, dark colored, that is blood in urine, hematuria, right renal angle tenderness, always think about pyelonephritis. Pyelonephritis is very common in female compared to male. Why? Because of short urethra, there is very high chance of ascending infections, most commonly caused by Escherichia coli. So all these acute conditions, 6 conditions I have mentioned, that is pyelonephritis, pancreatitis, and cholecystitis, you study both acute as well as chronic conditions. Then alcoholic liver disease, essay question. Hepatitis is an essay question. You must know what are the histological features, okay, of acute hepatitis versus chronic hepatitis. Histological features of acute hepatitis versus chronic hepatitis. Cholecystitis case, a patient comes with the complaints of right upper quadrant pain. On examination, the patient winces due to pain, okay, and there is tenderness also associated with elevated WBCs, or what is your diagnosis? Acute cholecystitis. That is called as Murphy's sign, positive Murphy's sign, or sometimes they will ask, the patient comes with a right upper quadrant pain, Murphy's sign was positive. So it is a case of acute cholecystitis. Acute cholecystitis. Rokitansky-Askov sinuses. Rokitansky-Askov sinuses are seen in acute or chronic cholecystitis. The answer, chronic cholecystitis. In chronic cholecystitis, Askov-Rokitansky sinuses are present. Very important MCQ. Askov-Rokitansky sinuses are present in chronic cholecystitis. Then, make sure you study about hepatocellular carcinoma. Just an outline, superficially at least you read about hepatocellular carcinoma. Remember a very important point, hepatic adenoma. Hepatic adenoma is associated with what? Increased use of oral contraceptive pills in female. In female, they use more OCPs, right? Oral contraceptive pills. They have a highest risk of getting hepatic adenoma. Remember, OCP is not associated with hepatocellular carcinoma. Hepatocellular carcinoma has no relation with OCP. Hepatocellular carcinoma is associated with chronic alcoholism, hepatitis B, and hepatitis C. Once that is done, let us go for the next chapter, breast. Fibroadenoma, Phyllodes tumor, carcinoma of the breast. Hepatocellular carcinoma case scenario. Okay, a patient who comes with weight loss, loss of appetite, jaundice, right upper quadrant pain. Okay, and she's a chronic alcoholic, or there may be an IV drug abuses history indicating hepatitis C virus infection. On palpation, multiple tender nodules and hepatomegaly was found. What is the diagnosis? It is hepatocellular carcinoma. Hepatomegaly, multiple tender nodules, jaundice, weight loss, that too in an old age, 50, 60 years, it is hepatocellular carcinoma. Or else they will give, the patient died on an autopsy. You found that what? There is multiple tender nodules and hepatomegaly. An autopsy, resected specimen. Okay, resected specimen. Then you have to think about hepatocellular carcinoma. In breast, fibroadenoma, mobile breast mass in an young lady. Mobile breast mass, breast mouse we say. Fibroadenoma is a mobile breast mass. Okay, that is fibroadenoma. Then Phyllodes tumor. Phyllodes tumor, just read the question, case scenario won't be asked. Then of course CA breast, well worst case scenario, don't miss CA breast. Top to bottom study CA breast. What are the prognostic factor? What is luminal type A, luminal type B, basal type? Remember, basal type is triple negative breast cancer. ER negative, PR negative, HER2 negative, worst prognosis. Triple negative breast cancer. Okay? Yeah. Then BRCA1 mutation, BRCA2 mutation. BRCA2 mutation is associated with increased risk of male breast cancer and prostate cancer. BRCA1 mutation is associated with increased risk of breast cancer and ovarian malignancy. The next chapter, kidney. In kidney, nephrotic versus nephritic. In a child nephrotic-like picture, your diagnosis should be minimal change disease. Most common type of nephrotic syndrome in a child, minimal change disease. Most common type of nephrotic syndrome in adult, your diagnosis should be membranous glomerulonephropathy. What the question mark? Can you clarify that? Most common type of nephrotic syndrome in child, minimal change disease. Most common type of nephrotic syndrome in adult, membranous nephropathy. HIV, in MCQ, if they ask what is the type of nephrotic syndrome, you have to go for FSGS, that to collapsing variant of FSGS. Or else in case scenario with HIV patient, we have to go for, in case scenario, there is essay question if they ask, no, we have to go for membranous nephropathy. Should we go with CA breast? I don't understand the question. Can you please type it in detail? Okay. Dyscohesive cells in FNAC. What should be the diagnosis? CA breast or lobular breast carcinoma? Dyscohesive cell. Why is this dyscohesive? Because of loss of E-cadherin. E-cadherin is associated with lobular carcinoma of the breast. Go for lobular carcinoma of the breast. Go for lobular carcinoma of the breast. In CA breast, the FNAC will be hyperchromasia, altered nuclear cytoplasmic ratio, completely disintegrated breast cells, okay, more hematoxylic, there is more bluish. All these things you can go for CA breast. But dyscohesive means you can go for E-cadherin mutation in lobular carcinoma of the breast. That is the Indian file pattern. Remember, lobular carcinoma of the breast, you get the Indian file pattern. Okay, Indian file pattern. Okay, so then we will discussing about nephrotic and nephritic. Then remember, study about Alport syndrome, study about post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis following an episode of sore throat, a child is presenting with a dark cola-colored smoky urine. Diagnosis: post-streptococcal glomerulonephritis. It is the most common nephritic syndrome in children. Most common nephrotic is minimal change disease. Most common nephritic is post-streptococcal glomerulonephritis. Study about Alport syndrome. FSGS cannot be asked as a case scenario. It can be most commonly asked as an MCQ. Study the different varieties of renal cell carcinoma, especially clear cell carcinoma. Clear cell carcinoma of the kidney. Clear cell carcinoma of the kidney, very, very important question. Wilms tumor, very, very important. I have already mentioned in paper 1. Again, I am mentioning here. Wilms tumor is very, very important. Child presenting with a renal mass, hematuria, palpable abdominal mass. Think about Wilms tumor. What are the various syndromes associated with Wilms tumor? That is also important. Most common paraneoplastic syndrome in renal cell carcinoma. I am expecting this MCQ this year. Most common paraneoplastic manifestation of renal cell carcinoma. Polycythemia. Answer, polycythemia vera. Polycythemia or raised ESR is the most common paraneoplastic syndrome in renal cell carcinoma. Remember, Wilms tumor, very, very important. Then acute versus chronic pyelonephritis. Thyroidization of the renal tubules is a feature of chronic pyelonephritis. That means once you see the renal, polycythemia. Polycythemia is the most common paraneoplastic manifestation of renal cell carcinoma. Some others say hypertension, but I will go with polycythemia for you. Okay, polycythemia is a better answer. Polycythemia is the most common paraneoplastic syndrome associated with the renal cell carcinoma. Chronic pyelonephritis, you will get thyroidization of the renal tubule. What do you mean by thyroidization? When you see the PCT and the DCT and the Bowman's capsule, the loop of Henle, it will look like thyroid globules. It will look like a thyroid gland. That is called thyroidization. Very, very important MCQ. Thyroidization. Renal cell carcinoma important. Okay. Then, pyelonephritis important. Pyelonephritis is important. Once that is done, the next question is urinary bladder carcinoma. Very rarely urinary bladder and prostate carcinoma, Gleason score. All this I have put voice messages in the group. If you can't read from the book, at least share these voice messages. Gleason score, the different grades in Gleason, hematobium, okay, parasite. So schistosoma hematobium, aniline exposure associated with increased risk of bladder carcinoma. See, reason why I couldn't display and the questions is my lack of time. Okay, so that's why I am making this very late night sessions also. The reason is I couldn't find time to sit and type everything. So that's why I thought of just discussing verbally. Fine. And all these things, don't worry, all these things I have already mentioned in the path revision PDF. Each question with the characteristic pinned in the case scenario, I have typed out a PDF. So that's why I asked you to go through that PDF before attending this session, which will be more effective. Okay, that is the reason. Fine. Yeah. So initially I also thought of sharing like that, but I'm really very sorry because I couldn't get time to do that. Fine. So bladder carcinoma, that important. Okay. Yeah, definitely at the end of session I will explain how to write the answers. Don't worry. So that's about the chapter renal kidney. Yes. Then next chapter, male genital tract and female genital tract. First question. Pre-malignant lesions of penis. Pre-malignant lesions of the penis. Pre-malignant lesions of the penis. I am expecting this question because one supplementary exam they have asked this question. Pre-malignant lesions of the penis. Second question. Paget's disease of vulva. Paget's disease of bone is important. Vulva is important. Breast is important. Three Paget's disease important. Paget's disease of the breast, vulva and bone. Seminoma or dysgerminoma. Choriocarcinoma. Endodermal sinus tumor or yolk sac tumor. Very, very important. Okay, once again I will be repeating. Paget's disease of the breast, Paget's disease of the bone, Paget's disease of vulva. Okay, all these are very, very important. Pre-malignant lesions of the penis is important. Seminoma important. Yolk sac tumor is important. Dysgerminoma. Choriocarcinoma. Tell us the enzymes evaluated in each ovarian and testicular malignancy. In seminoma, placental alkaline phosphatase is increased. Even beta HCG is increased. LDH is increased. Choriocarcinoma, HCG is a unique marker. Yolk sac tumor, alpha fetoprotein is increased. Okay, from this only they will ask. Seminoma is also positive for OCT34. Seminoma is also positive for OCT34, OCT3 bar 4, OCT34. I will type in the box, OCT34. Okay, OCT34 is the newer marker for seminoma. OCT34 is the newer marker for seminoma. A female presenting with abdominal mass, a female presenting with abdominal mass on elevated bilateral ovaries are ovaries are enlarged. What is the diagnosis? Ovarian malignancy. Classify the epithelial tumors, sex cord, stromal tumors, germ cell tumors. Make sure you are studying this classification very thoroughly. What are the epithelial tumors? What are the germ cell tumors? And what are the sex cord, stromal tumors of the ovary? In testis, seminoma important. Choriocarcinoma important. Yes, I will make the audio for chapter 1 and I will send in group. Okay, don't worry. Next, uterus, fibroid important. Fibroid important. A reproductive age group woman comes with what frequent episodes of bleeding. Abdominally, a mass was palpated. What is your diagnosis? Your diagnosis should be uterine leiomyoma, smooth muscle tumor of the uterus called as fibroid. Molar pregnancy is important. A patient comes with frequent episodes of bleeding, vaginal bleeding. On examination in USG, there is snowstorm appearance. Snowstorm appearance in USG. What is your diagnosis? Hydatidiform mole. Partial mole versus complete mole. Important. As far as staging is concerned, study only cervix staging. Okay? Cervical carcinoma staging. Cervical carcinoma staging is important for your level. They won't ask staging from any other organs. Cervical cancer is study. If you don't study cervical staging also, no problem. Make sure you are studying a female cervical carcinoma. A female comes with a complaints of post-coital bleeding. On examination, a visible, friable, cauliflower-like growth on the cervix. What is the diagnosis? Cervical carcinoma associated with human papilloma virus 1618. Human papilloma virus 1618. SIN1, SIN2, SIN3. That grading is very, very important. Study that. SIN1, SIN2, SIN3 important. Pap smear important. What are the different cells in pap smear important? I have already sent the PDF to the group. Make sure you are studying the pap smear. Liquid based cytology, FNAC of thyroid, FNAC of breast. All these are very, very important questions. FNAC of thyroid, FNAC of the breast, liquid based cytology, pap smear. Okay. Then endocrinology. Diabetes mellitus, Cushing syndrome, pituitary tumor, prolactinoma, Graves' disease, Hashimoto's thyroiditis, papillary carcinoma. A male presenting with midline neck swelling associated with weight loss, dysphagia, hoarseness of voice, thyroid malignancy. For my batch, thyroid malignancy was the essay question. Papillary carcinoma, follicular carcinoma, medullary carcinoma. Prostatic cancer, very rarely asked. I have already told you, prostatic cancer, bladder cancer, Gleason staging, very rarely asked. Just hear and study from the audio messages. Prostatic carcinoma, urinary bladder carcinoma, and Gleason's grading important. Diabetes important. Diabetic nephropathy, Kimmelston-Wilson lesions, diffuse nodular glomerular sclerosis, Armani-Epstein lesions. All these are very, very salient points you have to remember in diabetic nephropathy. Gross as well as histopathological features of diabetic nephropathy is very, very important. Pheochromocytoma is important. Men's syndromes are important. Type 1, type 2, type 3. Sorry, men 1 syndrome, men 2A and men 2B syndrome. Men syndrome is important. Pheochromocytoma is important. In pheochromocytoma, there is characteristic histopathological finding called cell balance nest. A male coming with recurrent episodes of sweating, palpitations, and high hypertension. There is malignant hypertension. Blood pressure 220/140. What is your diagnosis? Pheochromocytoma. Elevated levels of metanephrine and vanillyl mandelic acid in the urine. Diagnosis: pheochromocytoma. Histopathology: cell balance nest. Men syndrome is important. Bones. Osteosarcoma is important. Osteosarcoma is important. Ewing sarcoma is important. It can be asked from paper 1 also. Paper 1 Ewing sarcoma. Okay, that is diseases of childhood. They can ask Ewing sarcoma. Ewing sarcoma, neuroblastoma, Wilms tumor, cystic fibrosis. Very important questions from childhood chapter. Here, osteosarcoma is important. Ewing sarcoma is important. Giant cell tumor is important. A female presenting with a localized swelling over the distal end of the radius or ulna, distal end of the femur. X-ray shows soap bubble appearance. Diagnosis: giant cell tumor. Robbins has mentioned that soap bubble appearance is seen in giant cell tumor as well as aneurysmal bone cyst, A, B, C. But whenever this question is asked in your university exam, don't write A, B, C as the answer. Always write giant cell tumor or osteoclastoma. Rheumatoid arthritis is important. Rheumatoid arthritis is important. Gout is important. Pseudo gout is important. Gout, pseudo gout, rheumatoid arthritis important. Okay. From the chapter skin, squamous cell carcinoma of the skin, basal cell carcinoma of the skin, malignant melanoma of the skin. 3 important questions. Psoriasis, lichen planus, blistering disorder, pemphigus vulgaris. Psoriasis, lichen planus, blistering disorder, pemphigus vulgaris. Squamous cell carcinoma of the skin, basal cell carcinoma, malignant melanoma. Malignant melanoma is associated with sonic hedgehog signaling pathway mutation. SHH, remember. So that's about skin. Then I have mentioned bone joints also. Duchenne muscular dystrophy important. Sonic hedgehog signaling pathway is associated with basal cell carcinoma. It is not malignant melanoma. Sonic hedgehog signaling pathway mutation is associated with basal cell carcinoma. In muscles, Duchenne muscular dystrophy is important. Duchenne muscular dystrophy is important. Second question, Leber's hereditary optic myopathies, mitochondrial muscle disorders. Okay, mitochondrial myopathy with ragged red fibers. Mitochondrial myopathy with ragged red fibers. Mitochondrial myopathies are important. Mitochondrial myopathies and Duchenne muscular dystrophy is important. Lipoma is important. Lipoma is important. Swelling over the forearm. A patient comes with swelling over the back. Fluctuation test positive. Sorry, slip sign positive. You would have studied in surgery. Slip sign positive. The swelling will slip away from our fingers while palpating. Slip sign positive. Lipoma. Schwannoma is important. Schwannoma is important. In CNS, bacterial meningitis is important. Alzheimer's disease is important. Parkinson's disease is important. As far as brain tumors are concerned, ependymoma, pilocytic astrocytoma, medulloblastoma. Ependymoma, pilocytic astrocytoma, medulloblastoma. Remember, fried egg colonies are seen in oligodendroglioma, MCQ. Fried egg colonies are seen in oligodendroglioma. And next, last question. Psammoma bodies are seen in meningioma. Psammoma bodies are seen in meningioma. Psammoma bodies are seen in meningioma. From eye, from the chapter eye, retinoblastoma, choroidal melanoma. Retinoblastoma and choroidal melanoma. Okay, retinoblastoma and choroidal melanoma. How to present the answers in the exam? Write etiology, pathogenesis, gross histopathological features. But remember, in your university exams, question will be very specific. They will be giving a case scenario. They will be asking you to write the pathogenesis and the gross and histopathological features. Just write that. There is no meaning in writing answers based on the number of pages. It was once a trend. Now, if you give the correct answer, if it is less than 1 page also, you will be given marks in your university exams. Okay? There is nothing called marks based on the number of pages. It has been outdated. Diagnosis should be correct. Pathogenesis should be correct. Gross and histopathological salient points you should have written. Then you will get marks. So, I have tried to cover almost the possible questions from all chapters in chapter that is paper 2, systemic pathology. You know, systemic pathology is a very vast topic. So try your best in studying maximum number of questions. Okay, because you won't get time after paper 1 to study for paper 2 usually. So can we wind the session? Infectious lesion, TB, malaria, syphilis. TB, malaria, syphilis. Okay, tuberculosis, malaria, syphilis. Okay, just go to the YouTube channel playlist and watch those videos in high speed. Okay, just the salient points you pick up. That's enough. Tuberculosis, malaria, syphilis. Okay, pa. Thank you. Okay.